Hello friends, so welcome to the next lecture in the stroke imaging series. In this lecture, we shall discuss about the role of imaging and the CT findings in infarct, ischemic stroke. So quick revision, we know that stroke it can be due to two causes mainly. One is the ischemic, which account for about 80%, and the other can be due to the hemorrhagic one. So today we shall confine our discussion to the role of imaging in ischemic stroke. So there are two modalities that we have. One is the CT scan. This image is the CT. The other one is the MRI. In this lecture, we shall only discuss about the role of CT in ischemic stroke. So before going to topic proper, you should know the goals of imaging. First and foremost, you should confirm that there is an infarct. What is an infarct? It is the end result of a ischemic stroke. You've got a blood vessel and you've got a clot here, as a result of which what happens? The blood flow is hampered. So the tissue will die due to lack of blood supply. So two is to rule out any hemorrhage. Why? Because we know that the mainstay of treatment of ischemic stroke is to revascularize or undergo reperfusion. Our aim is to re-establish the flow either by giving anticoagulants or by giving antithrombolytics. Okay? So, if the cause of stroke is due to hemorrhage, very small percentage can be due to hemorrhage, that is intraparenchymal bleed. What happens when you're going to give this treatment? You're going to do more damage than good. So always remember, our aim is to rule out hemorrhage in suspected case of stroke. And finally, you have to select the candidates for reperfusion. So by the end of the series on stroke imaging, I'm sure we would have answered all the three questions. So coming to the role of CT. Before going to the topic proper, you should know the merits and the demerits of CT. If someone were to ask you, is CT the investigation of choice for confirming infarct? The answer is no. Why? CT is not at all sensitive in picking up an infarct. Then why do you go for CT? So first let's take the merits. It's easily and readily available. So almost in most of the basic health units, reasonably good ones, you have got a CT. So in cases of suspected stroke, a patient has to confirm the finding. More importantly, his aim is to rule out what? Hemorrhage. Okay? So it's very easily available. And secondly, as I said just now, the aim is to rule out any hemorrhage. Why? Even if you're getting a normal CT, the patient may be still having an ischemic stroke. The clinician can give treatment if he or she is a candidate. But if there is any foci of hemorrhage, no, the answer is a big no. You're not supposed to give thrombolytic or anticoagulant therapy. So okay, see, it is excellent to rule out hemorrhage. So somebody may ask, why not MRI? MRI, it's a very time-consuming process. And to rule out hemorrhage, you need multiple sequences. Okay, not just one image is enough. You have to obtain multiple sequences. Only then you can confirm that it's a bleed, because bleed has got various morphology in various sequences in MRI. So readily available to rule out hemorrhage, it is CT. Okay, it's less time is required. Maybe within 1 to 2 minutes, the process is over. And you don't have to worry about any contraindications of CT. The only risk with CT is what? Radiation. But you have to have a weighing between risk versus benefit. This is an emergency condition, so there is no question of postponing CT saying that there is radiation. No, that's a big no. So these are the merits by which you are opting for CT. Because now, what are the demerits? Just as I said, very less sensitive to detect stroke. An important point to remember is that If you're able to identify infarct on a CT scan, it means significant time has elapsed. That is, minimum 6 to 8 hours of onset has passed from the event of insult, right? And so it may not be useful to make a significant impact on treatment. So that is one of the greatest demerits of CT. So then small lacunar infarcts. What do you mean by lacunar infarcts? These are due to obstruction, occlusion of penetrating vessels. Okay, they may be missed easily in CT. Even if a CT is normal, the patient may be having an ischemic stroke. You cannot pick those conditions. So keep this thing in mind. But still, we're going to, CT is the most common ordered investigation. Now, this is a very important concept. Time is brain. That is, the time of detection of the underlying pathology is the key to the prognosis of patient after treatment, or even key to deciding whether you can go for treatment or not. Why? So actually what is happening there? You have got a blood vessel and it is being blocked. There are two zones. Okay. One is the core infarct zone, core of the infarct, core zone. That tissue is dead and gone forever. That is, and surrounding that, what you've got at risk area, also known as the penumbra. So this is a very important concept. I'll be touching upon this in a separate lecture. Our aim is to salvage the penumbra. So where lies the importance of time? With increasing time, the area of infarct progresses. So if this is a black area here, is the infarcted core, and this area is the penumbra. With progression of time, the infarcted area expands, and finally there is no useful penumbra that you aim to salvage. So there lies the importance of timing. Okay. So similarly, even in imaging, there comes the role of time. You can divide the imaging of CT in ischemic stroke or infarct based on timing. It can be hyperacute when, that is, the duration of insult is less than 6 hours. You're going to, the patient is presented with weakness. Within 6 hours of onset of weakness, you're going to image. That stage is known as the hyperacute stage. Then there is a stage called acute stage. What's the time window for that? It's between 6 hours to 48 hours. So the imaging feature at hyperacute and acute is going to be different. Okay? And then what is going to happen? Then there's a subacute stage where the duration is between 48 hours to 2 weeks. And finally, you've got a chronic stage. Okay? Now, we're going to discuss the signs that or the things that you have to go for or look for in hyperacute stage of infarct. First and foremost is the dense MCA sign. Dense MCA sign. We know that the most common territory affected in infarct is which one? Anterior circulation. And the most common vessel to be affected is MCA. So, dense MCA sign, as you can see, what do you see here? You see a thick, dense cord-like structure. What is that? It is a clot, either thrombus or emboli, lodged within the proximal M1 segment of MCA. You can see this sign, but you may not always see it. It depends on the etiology, okay? So if you're able to pick it up, you have to look for it. You have to look for it in cases of dense hemiplegia, in cases of suspected stroke, and if you report it, it can give a significant impact. Now similarly, a counterpart of dense MCA sign, that is a second sign called MCA dot sign. So what does it mean? You're going to see a hyperdense focus. See here. Where is it? It's within the sylvian fissure. What runs in the sylvian fissure? What runs? One of the branches of MCA. To be precise, the M2 segment runs in the sylvian fissure. So if a clot or a thrombus is lodged in the M2 segment, it can show dense dot sign, MCA dot sign. Okay? But remember, whenever you're going to look for these signs, there is an important pitfall. What is it? Sometimes the vessels can appear hyperdense in CT. What are the causes? Slow flow or due to hemoconcentration. Where else can you get hemoconcentration? A dehydrated patient, in patients with polycythemia, high HB, okay, high PCB. All these patients can too present with dense vessels, not just the MCA, but entire vessels in the brain, including the sinuses, including the rest of the vessels like the basilar artery, ACA, all those vessels, you can pick it up. All will be hyperdense in such conditions. So when you are going to report it, you have to report it in the appropriate clinical setting, or you may end up in great damage. Okay. So these are the two important early signs: hyperacute, infarct. Now coming to the third sign. So take a closer look at this image. Is it normal? Well, I'm saying it's not normal. So at one go, you may say, yeah, it looks normal. What's the problem? But take a closer look. The advantage of human body reporting, imaging is what? The body actually is symmetrical. You've got two limbs, two upper limbs, two lower limbs. You've got right side of the body, you've got left side of the body. So it's easy to compare. You've got right hemisphere, you've got left hemisphere. So split the brain into two. Compare on each side. What is missing? Spot the difference. It's like playing a game. Spot the difference. Okay? What do you see here? You can see, so before saying, you should remember an important saying. Your eyes see only what your mind knows. So that's very important, of great significance in radiology. So in CT, remember, the gray matter is denser than white matter. So where is the gray matter? The cortex is made of gray matter. The basal ganglia is made of gray matter. So that should appear denser. Denser means whiter than white matter. It's subtle, but still it's significant. So as you can see, this is the cortical gray matter. It's brighter compared to the white matter. So you're going to look for that in this case. So here the cortex is bright, here cortex is bright, white matter is less bright. Then what is the other gray matter structure that I told just now? The basal ganglia, the caudate nucleus, and the lentiform nucleus. Look on the opposite side. Oh my god, I'm not able to spot the bright structures. Yes, a little bit over here, a little bit over here. But where is the rest of the chunk? It's missing. So that means there is obscuration of the lentiform nucleus. That's the next important early sign of hyperacute infarct. So you're getting loss of the brightness of the gray matter. I'll give you the reasoning in a couple of slides. Why does it happen? So remember, this is an important sign. Obscuration of lentiform nucleus. So if you're not convinced, look at this normal brain CT. What do you see? This cortex is bright, this cortex is bright. White matter, not so. This caudate nucleus and lentiform nucleus is bright. Here too, it's same. Now compare. This is bright, this is bright. Only a part of it is bright. Rest is gone. Okay? So that shows that obscuration of lentiform nucleus. It's a subtle sign. But what do you have to do? You have to look for it. And more importantly, look for it in the stroke window. What do you mean by the stroke window? You have to adjust the window width and the window leveling such that it is in the range of 32 and 8 HU, so that you can appreciate these subtle findings very well. Now coming to the next sign. What is it? Again, I'll ask you to take a closer look. I'm going to look for what? The gray-white differentiation. That's what I'm going to look for. Over here it's present, over the opposite side it's present. And what about the inferior part of the lentiform nucleus? Yeah, pretty much they are bright on either side, comparative. Then what is yet another important gray matter structure that you have to go to look for? You have to look for the insular cortex. Again, insular cortex. Cortex, so it means it's a gray matter. Where is it? This is the insular cortex. On the right side it's bright, but what happens on the left side? It's not bright. So I'll give you another image for comparison. See, this is bright here, it's bright here, which means it's normal. But look again, it's bright here, there is loss of the insular, we call it insular ribbon sign. Loss of insular ribbon sign. Okay, so that is yet another subtle early sign of hyperacute infarct. Now I'm going to show you the next important sign of hyperacute infarct. What is it? Look carefully. Is the symmetry maintained? What am I going to look for? The symmetry. Is it maintained? No. If you cannot appreciate, take a closer look. What is happening? I feel the left side is hypodense related to right. Why do I say so? I can't make out the gray matter, white matter distinction on the left side. See, I can make it out here. I can make it out up to here. But further that, it's gone. That is, there is obscuration of the gray matter, white matter differentiation. There is generalized cortical hypodensity. So this is yet another important sign of hyperacute infarct. Now coming to, so this is another image for comparison. This is normal. See, this side you can appreciate the gray matter, white matter distinction, but not here. Okay, so this is a case of hyperacute infarct. Now I'm going to give you the reason, the major concept behind what is striking in hyperacute stage. Now I'm going to give you the basis for picking up findings in hyperacute infarct. What is it? It is a cortical or gray matter hypodensity, be it in the signs of obscuration of lentiform nucleus, loss of insular ribbon sign, or the generalized cortical hypodensity. We are going to look for the loss of the hyperdensity of the gray matter. So as I said, in CT, the gray matter is more hyperdense than white matter. Why? The reason is that the gray matter has got greater cerebral blood volume than the white matter. Okay, so what happens in infarct, in ischemic stroke resulting in infarct, what happens? There is a decrease in the cerebral blood volume, and the most of it is burnt by the gray matter, so its hyperdensity decreases. This is the most acceptable hypothesis behind these findings. The second important concept is that there occurs cytotoxic edema. What is edema? Edema, how does it appear in CT? It appears as hypodense areas. So, okay, clot is blocking the blood supply. There is decrease in the blood flow. So what happens? For the cells, the nutrients, the energy source is cut off. So what maintains the homeostasis? The sodium, potassium, ATPase. It maintains the homeostasis. So what happens if there is an energy failure? This pump fails. And what happens when the pump fails? The cells will become edematous. There is influx of water. The cells will become edematous. So in early stage, it is cytotoxic edema. And as the time progresses, there is a break in the blood-brain barrier and you get vasogenic edema. So the second reason for the loss of gray matter hyperdensity is said to be the cytotoxic edema. But the more acceptable theory is that there is decrease in the cerebral blood volume and hence making these subtle signs that you have to look for in hyperacute infarct. So summarizing the hyperacute infarct findings, there is dense MCA sign, then there is MCA dot sign, then there is obscuration of lentiform nucleus, then there is loss of insular ribbon sign, and finally there is cortical hypodensity, making the gray-white matter differentiation difficult or indistinct. Okay. Now coming to the imaging feature of acute infarct. So this is very apparent. Anybody can say, okay, the left side is abnormal. What is abnormality? There is generalized hypodensity. So what is happening? This is the imaging feature of acute infarct. And remember, any pathology other than hemorrhage usually becomes hypodense on CT. Then why do you call this infarct? It is following a vascular territory. Very important. A hypodensity following a vascular territory and also causing loss of gray matter, white matter differentiation is the key to identify stroke, acute infarct. Okay, so this is the reason why what I said. By this time, if this finding we will not miss in CT. By this time, most of the damage is done. Okay, so remember, acute infarct, two features. Hypodensity. What kind of hypodensity? That respects the vascular territory. And there should be loss of gray matter, white matter differentiation. And why do you get this hypodensity? As I said, failure of pump, breakage of blood-brain barrier. So the hypodensity progresses and becomes more apparent to our eyes. Okay. Now coming to the features of subacute infarct, that is between 48 hours to 2 weeks. Three important features are there. First and foremost, it is similar to acute. That is, there is progression of the hypodensity, hypoattenuation. That is one feature. Second feature is known as the hemorrhagic transformation. What is hemorrhagic transformation? What is seen here? There is a hypodensity. What about in this image? There are blood density hyperdense areas also within it. So this is known as hemorrhagic transformation. So what is the pathology? We know there is an infarct, brain is dead. So what does the body try? Body tries to somehow salvage it. By doing what? By diverting blood from the neighboring territory, neighboring vascular territory, collateral flow. But what happens? These are established rapidly, newly formed vessels, very leaky. Okay, so they tend to bleed. Second reason is we are going to attempt to treat the patient by giving anticoagulation or thrombolytic therapy. So what is happening? It can bleed. The complication is bleed. So these are the two important theories behind hemorrhagic transformation, and that is okay. The third phenomenon is known as fogging effect. It's rather interesting event. So I'm going to take you to a series of evolution of infarct. Initial presentation, less than 6 hours. What do you get? Dense MCA sign. Later, it is apparent. Serial imaging done 2 days later. See, this is the effect. Now it's a stage of acute stage. Now I'm going to image the patient, say after 10 to 14 days. Oh my God, what has happened? It's totally gone. The brain looks normal. Looks apparently normal. So, I'm confused. What is happening? This is known as fogging effect. So, imaging done say 1 or 2 weeks later, the onset of insult, where there is an established case of acute infarct, the brain looks normal. So, what is actually happening here? As we said, our body is trying to take over some defensive mechanism. So, there are proliferation of capillaries, but these are very leaky. So, what happens? The macrophages, lipid-laden macrophages will come out, they will deposit. The RBCs will come out, they will deposit. New vessels are proliferating, and what will happen? The body tries to reduce the edema. So, relative density of the gray matter comes back into effect. But this is not normal, but it looks apparently normal because all of these defensive mechanisms taking place in the body. So how do I confirm? I'm going to give IV contrast. This area will enhance in a gyriform pattern. See the opposite side, it's not enhancing. So normally brain tissue will not enhance because what? There is a strong blood-brain barrier. Only pathological processes will enhance. So this area is enhanced, which means that this is abnormal. This is a gyriform pattern of enhancement. So these are the important features in subacute stage of infarct. So summarizing, there is increase in hypoattenuation or increase in mass effect. There can be hemorrhagic transformation. It can be due to iatrogenic or due to collateral vessels bleeding out. And then the important one is the fogging effect, where the brain looks apparently normal. And then there is gyriform enhancement. These are the important imaging features in subacute infarct. Now coming to chronic infarct. This is very easy. It's very apparent. This is what is happening. The brain has become black. Why? The brain tissue is dead. Any infarcted tissue will undergo what? Gliosis. So that area will become very hypodense. Again, why not? It is a tumor because it is following a vascular territory. Black. These are the important findings. So, summarizing today's lecture, we have discussed about the role of CT in imaging. What is the merit and demerit? Then, We have discussed the imaging feature according to the stage of infarct: hyperacute, acute, and chronic. So I hope it is clear. In the next video, we shall discuss about the role of MRI, the MRI imaging features in infarct. Thank you very much.